Welcome to ePathshala and the lectures on social medicine and community health. Today we will be discussing healthcare delivery system, which we have been doing it in a series of lectures. And today this particular lecture will be on healthcare delivery system in India at the district level. We just finished because when we are talking of a word of appreciation for the development team under the guidance of Professor Vidya-mitra and his colleagues, along with his colleagues from Aligarh Muslim University. And like I have always mentioned, that learning objectives are the most important. Before any lecture is delivered, before any work is undertaken, or for any planning, learning, putting down in writing what are the objectives which are necessary, so that at the end of the day we know that what we have learned and we have achieved. So therefore, in this particular lesson, we have administrative organization of healthcare delivery system. We must know the healthcare setup at the district level. We must come to know the structural organization of healthcare delivery system, and we must know the job responsibilities of the district health officer and other officers of different public health programs at the district level. In other words, we have to know the working of this team at the district level. In the introduction, healthcare delivery in India has been envisaged at three levels, namely the primary, secondary, tertiary. District hospital is a hospital at the secondary referral level, responsible for the district of a defined geographical area, and it contains a defined population. The district accountability and the amount is going to be approximately the same for a particular state. It means it has to look at a particular population. But the geographical characteristics and the physical and the chemical characteristics of that particular population will differ from place to place, even as the geography differs from place to place over the entire state. So this is and obviously over the entire district. So in some cases it could be hilly, it could be watery, it could be under floods, it could be a simple dry ground, or it could be a desert. So in a district, according to the geography, that has to be taken into consideration when you are making your medical programs. All healthcare programs in a district are placed under a unified control, and it is a link between the state and the regional structure on one side and the peripheral level structures such as the primary health center, the sub-center on the other side. Very correct. Now, in continuing with this integration with the introduction, the district officer with the overall control is of course designated as the chief medical and health officer, or as the district medical and health officer. Now this chief person has both the medical as well as the health components under him, but this will further divide off into the medical and into the health section, which will have to work in coordination at the field level. These officers are popularly known as DMOs, that is the district medical officers, or the CMOs, that is the chief medical officers, and are overall in charge of the health and family welfare programs in the district. These DMOs/CMOs are assisted by the deputy CMOs and their program officers. States have reorganized their health services structures to bring all healthcare programs in a district under the unified control. To continue with the introduction, work as a middle-level management organization, and it is a link between the state and regional structures on the one side, and peripheral level structures and the primary health center and the sub-centers on the other side. And they receive information from the state and they transmit the same to the periphery by suitable modification. Like I said, you have to take into consideration the geographical structure, so that proper information is passed suitably to the peripheral level. And in doing so, it actually adopts the functions of a manager and brings out various issues of general, organizational, and administrative types in relation to the management of health services. This is a diagrammatic representation of the health service, of the distribution of the health services from the center to the periphery. And by means of center, we are taking it from the district level. So the district actually has a subdivision, and these subdivisions have the smaller areas known as the taluka or the tehsils. And they are helped by the community development blocks and the corporations. And the corporations will be, of course, closer to the urban areas, and the community development blocks will be in the rural areas as you move out in the district. These community development blocks have the villages and they have their panchayats, whereas the corporations have the municipal boards and the town area committees. And both, of course, like I've just mentioned, this is the rural setup and this is the urban setup. Now, in the administration, it will vary from place to place and down the ladder. At the district level, the principal unit of administration in India is, of course, the district under the collector. Most districts in India, of course, they are not known as collectors now, they are known as the IAS administration in charges. Most districts in India are actually divided into 2 or more subdivisions, and each in charge of an assistant collector. And then each division is, of course, again divided into tehsils or talukas in charge of a tehsildar. And a tehsildar usually comprises of 200 to 600 villages. So, at the tehsildar's office, you will have a collection of 200 to 600, the details of the villages and the setup therein. Now, to continue with the administration, actually the rural areas of the district have been organized now. In the rural part, we know that we've been talking, they are divided into the community blocks and community development, known as the CDBs or the CDOs, and known as the community development blocks, the area of which may or may not coincide with the tehsil. That's immaterial. He will have his books correct and these blocks have their divisions. So a block is actually what? It is a unit of rural planning and development, and it comprises approximately of about 100 villages and has a population, may cover a population of about 80,000 to 1,20,000 population in charge of a block development officer. Finally, there are village panchayats, which are institutions of rural local self-government. Now, each block will be again divided into the into the primary health centers. Each block will have its own primary health centers. Maybe it will have about 3 to 4 primary health centers, because each primary health center is actually looking after a population about 30 to 35,000. And so a block may have up to 3 to 4 primary health centers, and each primary health center in turn will have a sub-center with having a population of about 5,000. So we have administration down the line, and this is a very good channel through which all information as well as healthcare can flow. Now, within each district, of course, there are 6 administrative divisions, and they are the subdivisions, the tehsils, the community development blocks, the municipalities and the corporations, the village and the panchayats. And these, we are talking of both the rural as well as the urban, because the municipalities and the corporations and all will come into the urban sections, and the tehsils, community development blocks, villages, panchayats will come into the rural divisions. And administration at the subdivisional or the taluka level will be as follows. That is healthcare, which has to be rendered through the office of the assistant district Health and Family Welfare Officer, and some specialties are made available at the taluka hospital, and the assistant district health officer and family officer is assisted by the medical officers of health, lady medical officers of the general hospital, and these hospitals are being now gradually converted into community health centers. Now, a simple word about the community health centers. Now, these community health centers are the big hospitals which are looking after the rural population, catering to a population of maybe 80,000 to 101 lakh 20,000 populations. And these have actually specialists who are resident in these community health centers and in these hospitals. In fact, this community health center has in fact a 30-bedded hospital, and it has a surgery, it has OPDs, it has specialized services. So this basically functions like a proper hospital, albeit on a smaller scale. And the entire this, since it caters to so many primary health centers and to so many sub centers, all of them, this becomes the headquarter for that particular area, and this may or may not cover either one taluk or maybe 1.5 taluks. Now, to continue with the administration. Now, each taluka or the tehsil is again divided. Now, each division which we've been talking, it has been divided into tehsils and headed by a tehsildar, and it comprises of 200 to 600 villages. Now, when we say 200 to 600 villages, it means that tehsils are definitely bigger than the community development blocks, and they are, since they have only up to 100 villages. So that means maybe each tehsil will have nearly 200, depending on the number of villages it has. It will vary maybe as 2 to 6 2 to 6 community health centers will fall into each tehsil. So that means that is a big population which is being looked after, and that is nearly a population of what about 4 to 5 lakhs? Yes, 4 to 5 lakhs population. Now, we have just finished mentioning about community development blocks. Now, in the community development blocks, I just mentioned that it is actually a unit of rural planning and development, and it comprises of 100 villages. And maybe 2 to 6 such centers will come under one tehsil, which I've just finished mentioning. And each community development block will again look after a population of 80,000 to, it should be 1,20,000 population. Now, to continue to the urban part, this we were looking at the rural part, and to continue, we are now looking at the urban section. In the urban section, areas of the district are organized into following institutions of local self-government. That is, we have the town area committees. In areas with the population ranging between 5,000 to 10,000, we have to have a town area committee which deals with the public health care, and it has its own medical officer, but he is a health officer who will look after the health aspects and the environmental aspects of this particular area, along with the municipal board. And municipal boards are in the areas with population ranging from 10,000 to 2 lakhs, and it is headed by a chairman or a president, which is a very important post, since for example, in our cities and in the smaller towns, you have the municipal boards, and they are headed by these chairmen and presidents, and they have to see to the complete environmental care in its entirety. Besides, if there is an epidemic, then these people are the ones who set the emergency care into motion, which is absolutely important. Then, of course, we have the corporations, and corporations are over with population of 2 lakhs and above, and they are headed by the mayors. And they have approximately the same function. They will not take action, but as soon as the information of any natural disaster or any natural help is required, it goes to these they immediately set into force the entire health services of the district as well as of the local area. Now, the district magistrate, that is a collector or is from an IAS cadet, and the district development officer, his district development officer is also the same cadet, however, a slightly junior person. And they are also influenced by the local members of the parliament and assembly. Because whenever these local members of the parliament are selected and of the assembly, the MLAs and the MPs, their first motion is to see in their own areas how much of the health services, road construction, cleanliness, immunization services, and in general, the care which should be given to a community has to be registered by them so that no care is missed out at any cost. And they have to have the help of the chief district health officer, uh, and who actually has in his team additional district health officers, the DPA, the district tuberculosis officer, the district malaria officer, epidemic malaria officer, quality malaria medical officer, reproductive and child officer, who actually they are all DPH qualified, means diploma in public health, not necessarily MD in public health, but these they are actually responsible for the healthcare setup at the district level. And it is important to realize that if an epidemic occurs, then all these people set into motion their own wheels to control and to contain the problem at hand. But we have different programs. For example, the tuberculosis officer there, he is responsible for his area about the identification of the tuberculosis cases and their names being entered into the register and they being attached to a place where where medicine can be given to them at the home level. And of course, the malaria officer, he is in charge for containing the spread of the insects, and therefore that means spraying becomes important. Then the epidemic and spraying, and both he and the epidemic medical officers work hand in hand so that even any case. Now, what is an epidemic? Epidemic is where more than the normal number of cases are reported in a certain period of time. So, if you don't have malaria everywhere, you know that there is certain prevalence of malaria. If cases start coming more than that, immediately the motion of is set into motion that there might be a possible epidemic, and immediate containment, spraying, medicines, identification of cases has immediately to be done. And of course, the family planning services are an ongoing setup wherein the reproductive and the child officer is responsible for looking after the health of the family planning in this setup. Now, this is the organizational structure of a health department at the district level, wherein you have the deputy CMO, you have the ADHO, he is assisted by the district malaria officer, and they have a senior malaria officer, the leprosy officer. The district health education officer is a very important thing because he has to see that the mass education of the public is an ongoing process. Without mass education, without mass communication, it is not possible to spread knowledge of these diseases so that people are aware and report in time. Then you have the laboratory services, the medical superintendent and the MOs of the district hospitals. You have the tuberculosis. So tuberculosis, malaria, leprosy, health education, family planning, these are all important factors which have to be seen within the framework of the organizational setup of the health department. Now, yes, what are the responsibilities of the chief district health officer? He is actually responsible for planning and budgeting of the health service and the delivery infrastructure in the district, mobilizing resources for health service and delivery infrastructure, monitoring and evaluating the health services in the district, procuring medical supplies. In fact, he is basically the overall because he is also providing the technical guidance and support supervision to the health centers and to the community health centers, to the primary health centers, to the sub centers. So, every information has to go to the chief district health officer. He is also responsible for managing and accounting for financial and medical supplies and other resources allocated to the district. And it is important to realize that coordinating the maintenance of health equipments and facilities is an important part of his duties because without the health equipment which are required in the separate laboratories, it is important no health program can be carried out without additional help. Now, we are talking about national health policies for different programs, and we have to know how to interpret what is the policy, what are the demands and the requirements of the policy, and integrate it to the district health plans because this policy, which was framed at the center, which began as a seed and as a germ in the center, is now becoming a program with well-defined components, with well-defined manner in which it has to be given. So we have to learn how to integrate it to the district health plans. Then we have to learn how to tender advice on health-related issues to the district councils and other the stakeholders. We will mention what are the stakeholders because just a word here about public-private enterprises. In some places where we feel that the public economy is not sufficient, we invite stakeholders in terms of the private enterprises who become part and parcel of this service, and so therefore these are based on the public-private enterprises. Now then we have to learn how to carry on and monitoring the health programs, all the different programs. It's not only the service programs, but we have to carry out monitoring of each program and maintain the data so that we keep a check on whether it is on the increase or it shouldn't be on the increase, but it should be on a slight and gradual decline so that we are reaching the baseline or the zero stages. Then we coordinate the sensitization programs about the primary health center in the communities. The primary health center and its public must know what are the programs. Then carrying out human resource functions like identifying the manpower needs, training. Whoever is working in this setup needs to be trained. No man can learn everything at one shot. So therefore, each person in this program needs to be trained, needs to retraining, and he has to take back his intelligence and knowledge back to the field and to his work. So mentoring, promotions, leave, assessment, they're all part and parcel of the daily lives of these workers. And we have, of course, let us not forget the managing the health research. Research is an important document, and from that comes out certain guidelines wherein which can affect the future course of these programs. And we have to learn how to enforce the professional and service codes of conduct and ethics. Then we have to prepare and submit the periodic reports. Now, the responsibilities of the Chief Medical Officer or the Chief District Health Officer now we will be taking the programs separately. And in this we have to, now we are going to take up the tuberculosis program. We have to ensure that the higher priority is given to the tuberculosis control program and in the overall health activities so that the objectives of the RNPCP are achieved. What are the basic objectives? Basic objectives are to catch every case, contain it, bring it under the treatment, and see that if he is a positive, he becomes a negative, so that he is a safe person to be placed in the community and cannot infect others. Then we have to provide for this. For achieving the state of affairs, we have to provide all necessary resources within his command to the district tuberculosis officer for effective implementation of the program. Then we have to issue all necessary administrative instructions and facilitate all activities for successful implementation of the DOTS at the peripheral level. Now, for DOTS, each person has to be registered. They have to be motivated to come as and when the medicines have to be given. In the initial days, they may have to come twice a day, or they may have to come every day, till such a time when the tablets are given to them for a week and they consume it and they come weekly and show their packets and receive the new medicines. Then we have to ensure that all the MOs and the paramedical workers, the MPHs, the MPWs, that's the multi-purpose workers, the the auxiliary women workers are all involved in the RNTCP, because actually these are the people who are going out into the deep field areas, and it is there where we are going to get the cases. We have to ensure that all the proper we have to ensure that all the district tuberculosis committee meetings and all are held as per the guidelines, and we have to coordinate with and keep the administrative head of the district, that is the DM or the district collector, informed on the progress of the National Tuberculosis Control Program from time to time, and ensure his intervention in getting intersectoral coordination. We have to know how to review the program on a monthly basis with the various people concerned, that is the district tuberculosis officers, the MOs of the tuberculosis centers, the MOs of the primary health centers, and of the other places. Then what are the responsibilities of the district tuberculosis officer? Most important is he has to know that each and every case, the program is being implemented in his district on a proper level. Each and every case is being hunted out and put in the record, so that they will be included in the DOTS program, and each one will get his medicines in time till he shifts from a positive to a negative case. Planning and execution of the district annual action plan. Ensure identification of designated microscopy centers, very important. The DOT providers and the staff responsible for the DOTs, that is the medicines, these people must learn when to give, what to give, where to get the medicines, so that they are never without their stock of medicines. We have to arrange, maintain, distribute supplies, drugs, laboratory reagents, because we need to examine the blood, the sputum, and so that, because that is the one thing which is going to tell us that they are shifting from a positive to a negative. Now we have to again organize. We have to remember that in service training, continual training of any staff in this national programs are a must, because that is how they will get new knowledge and they will review the knowledge which they have. So all paramedical, medical staff of the peripheral health institutions must be trained from time to time. At least once in 6 months they must be trained. Now we have to learn how to supervise and support at the sub-district level, and with the help of the medical officer and the other district tuberculosis staff, ensure all the TUs and the CHCs, the block PHCs in the area are visited at least once every quarter. Then we have to learn how to compile and analyze the quarterly program performance reports of the district, send them to the state and national levels within the dates prescribed, because it is from there that the whole country will be able to examine the present situation of the tuberculosis program and of the improvements made in the different states. And if any improvement has not been made, it must be checked and examined as to why. Conduct the review meetings. So these meetings are all important. Now, responsibilities of the district malaria officer. Now, this is of course another important very program, and this is important because malaria was rampant in the earlier times. Some 20 years back, it was rampant. Today we have been able to control malaria, but it has not yet disappeared from our horizon. So therefore, this district malaria officer is a very important person. He ensures that the targets under the active and passive surveillance are achieved. Now, what is active and what is passive surveillance? Active is actively hunting for cases of fever with rigor and to know that these cases are there. Passive surveillance is one quick surveillance of the area to find out if there are any such cases who have finished their fever episode. He reviews the work of the surveillance inspector, the basic health worker, once in a month and makes a copy to the zonal officer. He arranges review of passive surveillance work of all the agencies. In other words, he has to take into account that the reporting of the program which is going on of the active cases, and if any active case is perchance it is found, immediate spraying of that entire area must take place in order to break the cycle of break the mosquito cycle. Now, one of the important another program is the leprosy. Leprosy has been in the country from times immemorial. At first, it used to be regarded as a disease wherein the people used to be shunned and kept at the corners of the villages or corners of the houses. In fact, but today leprosy is recognized, it is accepted, and we know that it is not a disease which can create trouble either mentally, physically to the population. But it needs to be controlled, contained, treated, and health education is a very important part as a part of the leprosy program. So we must, of course, plan and monitor the program, supervise all the staff, see to the fact that the drugs are available, and the other supportive drugs are also there. And we have to see that the officers, that is the Panchayati Raj or the community level functionary, the sanitation committees, the village health workers, they must be knowledgeable and they must have a better view of the fact that leprosy is not the disease which it was in previously. Responsibilities, of course, of the epidemic medical officer. Now, this is important because it could be epidemic once it comes all of a sudden. If there is any national hazard, for example, a flood situation or an earthquake situation, this is inevitably followed by an epidemic of some sort of the other. It could be an epidemic of flu, it could be an epidemic of malaria, it could be an epidemic of filaria. Whatever it is, the epidemic has to be, or of infectious diseases, and it has to be controlled because this is important so that once you break the cycle, at least it will stop and a lot more people of this very population which can be affected. And what is more important is that the population consists of the strong people as well as the weak people. So we must protect that this epidemic does not spread to the weaker section in health terms of the population. So we must be able to coordinate, monitor the implementation of the program for the promotion and strengthening of the epidemic preparedness and response, provide technical support, coordinate the development of the guidelines on the assessment of the district level, and in other words, absolutely be prepared and ready for the outbreak and for the team to spread into action fast. We should be able to coordinate the development and monitoring and evaluation of the guidelines in response to the breaks and other public health emergencies, support interventions to be undertaken for mobilization of technical, and through the capacity, we must strengthen the capacity for response through a regional and country network of rapid response teams. And for this, we have to provide technical support in preparation of the project proposals and appeals for mobilizing external resources to strengthen epidemic preparedness and response. For this, in fact, our health education material, our radio stations, our TV stations, they are all one big factor in being able to, in order to help today in controlling an epidemic of any proportion. And in summary, we'd like to mention just a few points that all healthcare programs in a district are placed under unified control. You can't have two masters. We have one master, he issues orders, and they have to be followed right down to the periphery level. It is a link between the state and regional structure and the primary health center and the sub-center. The district officer with the overall control is the chief medical and the health officer, or as the district medical and health officer, they are overall in charge of the health and family welfare programs in the district. And these officers play the pivotal role in the implementation of the program, along with administrative functions, record keeping, maintenance, prevention, and control of epidemic and disease outbreak. And with this, we would like to thank you for visiting ePathshala.